Now, our next condition is myocardial injury. If you have myocardial ischemia or the heart is missing oxygen for a prolonged period of time, then you may actually injure the heart. Remember, we said that an injury is when somebody pinches your arm so hard for a little while that when they let go, there ultimately is a bruise. Now, bruise gets worse over the next few days and may take weeks to heal. However, it will heal and your arm is going to be okay. So myocardial injury is also a condition of the heart where there's a bruise. It might affect it a little bit, there could be some pain, but given some time, it will heal. It's probably not in weeks, it's probably going to be in months. But that's myocardial injury. And this is also what we would know of as a heart attack. When we say somebody's having a heart attack, it's not just that they have chest pain and they're having ischemia. When injury starts occurring, this is a heart attack. So it doesn't mean that just because somebody had a myocardial injury or infarction, we have to differentiate between the two. So you can say my uncle had a heart attack, and then the real question is, did it go all the way to infarction? Is there dead tissue there forever? Maybe not. And that's why somebody can have a heart attack and be perfectly fine afterwards. It's just kind of a warning sign. Certainly an intervention needs to occur. Probably the cardiac vessels are blocked. They're going to have to go into there and do some angiography and unblock those vessels or put a stent in or whatever, some kind of intervention. But that's what you call a heart attack. Okay, so myocardial injury is a heart attack, and it shows up on the ECG waveform in a very interesting way. So as we look at that, let's take a look. You generally notice it's going to be in the QRS complex. Kinda. It's also part of the T wave. So normally what should happen is as you have your heart beat, the R wave comes up to form the spike, and then it comes down all the way to the baseline. That down writing of that wave is called the S wave. The S wave is supposed to go all the way to the baseline, and then some time goes by, and then a little T wave pops open. Well, when there's myocardial injury, what happens is as the S wave is descending, a T wave starts to form before the S wave gets to baseline. And what is caused there is what we call an elevated ST segment. The T wave is really taking off in the middle of the S wave, so that segment ends up elevated. It's supposed to be down at baseline. The S wave is supposed to finish at baseline, then go over and then do the little T bump. But in this case, that segment is elevated and it takes off in the middle of the S wave. So an elevated ST segment, you may have heard of this, is also called STEMI, ST elevation, basically MI, an ST elevation MI. Now there's different types of MIs, different types of myocardial injuries that are beyond the scope of the test, and we don't really need to know about them here. The one you need to know about is the traditional STEMI or the ST elevation. That means on the exam or on an ECG report, if it said there's ST elevation, that's a heart attack. And it's going to show up, and the wave is going to look like this. All right, so that's myocardial injury. If we see that, certainly it's an emergency. We need to treat the patient. What we're trying to do is give them oxygen and help their heart in such a way we could give them some drugs so their heart calms down so that they don't develop infarction, which is dead tissue that remains there forever. And next, there is myocardial infarction. This shows up completely different on the ECG waveform, and it is associated with a Q wave. Let's take a look at a Q wave to see what that's really all about. A Q wave is this teeny tiny wave that occurs after the P wave and right before the QRS complex. So you see the big spike that goes up, that's the R wave, that's the QRS complex, but right before it goes up, you should see a very small deflection from baseline right here. It's going to go down just a little bit. In fact, it's so little sometimes that it hardly even shows up on the ECG waveform. But it goes down just a little bit, it's not very deep, and it's not very wide. Well, when we have myocardial infarction, this Q wave is altered. What will you see? Let's take a look. What you'll see is that the Q wave becomes what we call profound or significant. So if you see that in a report, significant Q waves or profound Q waves, what we're saying is that the Q wave has gotten to be deep and possibly even wide. How deep? Well, there is a clinical definition there. It's really in comparison to how much the QRS complex goes up, and every book is a little bit different, but some books say if it's about a third of the height or a half of the height of the QRS complex going up, it goes down that far down, then that is considered a significant Q wave. There's also some width definitions there that we're not sure you need to know for the NBRC exam, but let's just take it a live rhythm strip of a pronounced Q wave. And so here, as you look at this, you can see that this Q wave is much bigger than the tiny deflection that you're supposed to see, and that would indicate that there is myocardial infarction. Now, there's something else you need to know here, and that is that what you don't know is that, yeah, there's infarction, there's dead tissue, but you don't know when it occurred. It might have occurred 4 hours ago, it might be occurring right now, or it could have occurred 10 years ago. Why? Because a Q wave shows that there's dead tissue, and they could have sustained a really bad heart attack 10 years ago. And so it really has to do with looking at the patient. If you're looking at the patient and you see pronounced Q waves, you just did an ECG on them, and they're sitting there laughing, watching TV, looking at a sitcom, then they're probably not in immediate danger, but they have probably had a heart attack. Now, if you're a respiratory therapist or a nurse, you're not supposed to ask them about this, but the doctor could do this. It happens all the time. The doctor will say, have you ever had a heart attack? And they'll say, nope. And the doctor's sitting there looking at pronounced Q waves, and they'll say, well, yeah, you have. We don't know when it was, but you have had one. Now, there's one other condition, and that we won't show here, but if you see elevated ST segments and pronounced Q waves, you could be having a tremendous heart attack right now, and the patient may be sustaining dead tissue right now. When you see that combination of rhythms, then this could be a killer. Very often patients don't survive that. In fact, it's often called, that combination on a rhythm is often called a widow maker. I have a brother-in-law that's a paramedic, and I was flipping through a book one day, and that rhythm just came up. Elevated ST segment, they were having a current heart attack, but there was also profound Q waves, and he interrupted the conversation, put his finger on the book, and said, that's a bad rhythm. That's right. And you'll get used to that as you look at those. But those are the things that you need to understand with regard to an MI. Okay, just in summary, we have 3 MIs. We have myocardial ischemia, injury, and infarction. Ischemia indicates that the heart is in need of oxygen and is indicated on the ECG waveform by opposing T waves and P wave directions. And then we have injury, that's indicated by an elevated ST segment. The injury is what you would call a heart attack, but if we intervene fast enough with oxygen and otherwise, then we won't have any lasting damage to the heart. And then there is infarction. Infarction is indicated by a pronounced Q wave. Once you have dead tissue from the infarction, you will always have a pronounced Q wave, so the ECG will always have that problem. That's the difference between myocardial ischemia, injury, and infarction.